afternoon, everyone. Welcome to today's Public Health Ontario Rounds presentation on COVID-19 and HVAC, a practical perspective. My name is Jenny Kim, and I'm a public health physician in environmental and occupational health at Public Health Ontario, and I have the great pleasure of moderating today's session. Before we begin today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Second, please also use the Q&A pod if you have questions during the session, and we'll save them all for our presenter to answer as many as he can after the presentation. A discussion and question period will follow, as I mentioned. If at any point during the session you experience any technical issues, please email capacitybuilding, one word, at oahpp.ca. That's capacitybuilding@oahpp.ca. And finally, I would like to declare that as the moderator of this session, I do not have any potential conflicts of interest to declare. That said, it is now my pleasure to introduce the speaker for today's presentation, Dr. Jeffrey Siegel. Jeffrey Siegel, PhD, is a professor of civil and mineral engineering at the University of Toronto and the Von Tannenbaum Chair in Civil Engineering. He holds joint appointments at the Dalla Lana School of Public Health and the Department of Physical and Environmental Sciences. He is internationally recognized for his work on indoor air quality generally and air cleaning specifically, and is a fellow of the American Society of Heating, Refrigerating, and Air Conditioning Engineers, or ASHRAE, and is a member of the Academy of Fellows of the International Society for Indoor Air and Climate. Jeff gave an excellent presentation in March on indoor air quality and COVID-19 for PHO Rounds, and that presentation is still available to be accessed through the PHO events website through presentations. So please have a look if you haven't if you weren't there in person or if you haven't had a chance to see it. But Dr. Siegel has kindly agreed to come back to give a second part because we heard the audience back in March. There were so many questions that we weren't able to get to, and there were lots of comments that we wanted to be able to offer Jeff an opportunity to provide a second part of the presentation to try and answer some of those outstanding questions. So thank you all for the questions. We are paying attention, and please today as well, please feel free to enter your questions into the Q&A pod. And without further ado, I will let Jeff take it away. Thanks, Jeff.
Thanks, Jinhee, and thanks for the invitation and for everyone's participation today. Just first, some disclosures and disclaimers, and some indications of bias and potential or disclosures of other relationships. And so what I want to do today is, in the March presentation, I talked a lot about the why and some of the details behind filtration and ventilation especially. And today I want to focus a lot more on the how and answer questions that arose, but also talk a little bit more about kind of the practical details about how you integrate ventilation and filtration into your plants. And kind of an overarching point here is that, we're clearly in a different phase of the pandemic than we were in March. So our goal here is still COVID-19, of course, but we should maybe be thinking more broadly about other infectious disease as well as other indoor air quality issues. And, to that point, there's a lot more in indoor air that's of attention, and we know from a lot of previous research that healthy indoor environments improve cognitive performance and learning, improve productivity, and have a host of other benefits, not to mention they reduce healthcare costs. And so there's a lot of reasons to think about the indoor environment and to pay attention to it beyond just COVID. So one of the models or slides that I showed in the previous presentation is this one. And this is this very brilliant model, the Swiss cheese model, where we need to have lots of layers to protect us against any infectious disease threat, or in fact, any indoor air quality threat, because none of the layers is perfect, right? There'll always be a passageway through it or some holes in it. And if those holes line up, you can get transmission. And so this layered model is really underlies a lot about how we should think about the indoor environment as a way of reducing some of those risks. And this layered model has some challenges. One of the challenges is what I'm going to call layer porosity. The layers aren't perfect. And so you can have a mask mandate and people can do different things in that mask mandate that of course limit the efficacy of masks. Similarly, I want to introduce this idea of what I'm going to call layer bypass. And so, you can go to, in let's say a classroom setting or a school setting, you can go to great attention to pay attention to something like physical distancing. And then you can have the corridors where people graduate and gravitate to, or very crowded. And, all of a sudden the classroom shouldn't be the focus, or you've neglected to include other spaces that matter too. So we have to think about both the individual layers as well as paths that the threat might take around individual layers. And because I'm going to be talking about ventilation and filtration, I want to make sure that I'm defining them in a way that's consistent. So when I say ventilation, I mean fresh air from outside, which by definition is free of COVID. And when I say filtration, I'm talking about air that's recirculated, so taken from the space and returned to the space, but it's been filtered to remove the aerosol and the droplets, the respiratory particles that cause infectious disease. So that's what I mean by them, but some reminders here. Ventilation and filtration, there's no magic here. They're not the silver bullet that's going to protect us. And in the context of something like COVID, they're not a replacement for all the primary measures, vaccination, masks, physical distancing, et cetera. In order for ventilation and filtration to work, they have to be done well. So some of what I'll talk about today is how to do them well. But the other comment about them is they offer a lot of benefits beyond just COVID-19. And specifically, they've been kind of underutilized in general, both for indoor air quality in buildings, but also in the pandemic response. So we have opportunities to do more with them than we have. And because I'm talking about ventilation and filtration, I have to talk about the elephant in the room. And this particular elephant is 5 microns, which you might know is the common cutoff between aerosols and droplets. And why I want to talk about that is, want to give kind of a little bit of a perspective from an aerosol science and a building science perspective. First of all, the idea of 5 microns or any other threshold really doesn't make a lot of sense because, of course, it's a continuum. A particle a little bit smaller than the threshold is going to behave quite similarly to a particle a little bit bigger than the threshold. And so, any absolute threshold, it's a continuum. This distinction has been very useful in acute healthcare environments, and I'm not suggesting that it not be used there, because obviously it's very, very successful. But I would point out that there are some really important differences between community environments and acute healthcare environments. Those differences resolve around the fact that in acute healthcare environments, staff are very knowledgeable about PPE and IPAC procedures. And there's attention paid to those things. There is typically much higher ventilation and better filtration. And most importantly, those things are actively maintained, which is not always true in a lot of community environments. And then, of course, there's also some important differences. For example, by the time a patient is in an acute healthcare environment, they're at a very different disease state and might, in fact, be less infectious. From a building science perspective, I look at any building as a connection, as a series of connected spaces, and they're connected through airflows. And both within each space and between spaces, there is this airflow network. And those flows can be quite large, and we don't tend to measure them in a lot of cases. So there can be a lot more going on than we're paying attention to by kind of a simple model. And then the last comment is from an aerosol science perspective, very large particles can move much, much further than 2 meters. So just 2 examples of that. There's a lot of pictures like this one available that show that a cough or a sneeze forms a coherent cloud that can move quite large distances and can have, of course, some quite large respiratory particles in it. This is some data from my own work where we went to about 84 residential buildings and took the dust off the filter that was in a central system and sized it. And you can see that the typical size of particle is about 30 microns or so in diameter. And so in order for those 30 and of course larger particles too to get to the filter, they had to travel long distances, often upwards of 15, 20 meters through a complicated distribution system and end up at the filter. And so this idea that large particles settle rapidly by gravity is not always consistent with the evidence. Now, that debate about transmission aside, I do want to point out that there is some good news since March. This is an article that I think probably many people are familiar with that looked at schools in Georgia, and they found a much lower incidence of transmission in schools that had a mask mandate, and importantly for this discussion, in schools that improved ventilation. And it got even better when there was also filtration present as well. Now, this is good news because it suggests that ventilation might work, but I'll point out there's not a lot of detail here. There's not how much was ventilation improved, what was the other details of other factors going on in these schools. And so, I don't know how far we can take this, but I'm glad that this type of data is being collected, and I would encourage more of it to improve the evidence basis. And I'll return to that point a little bit later in the presentation. So given that ventilation and filtration are important, I just want to briefly summarize what does doing each of those things well mean. So first, ventilation. Ventilation means providing as much ventilation as possible without compromising some of the core functions in the building. Things like comfort, humidity, temperature. Maybe in an environment with poor outdoor air pollution, you might have to manage that issue. And there's going to be a different answer about how much ventilation you can improve things in every building. In some buildings, you won't be able to add ventilation at all because of the nature of the systems. But the evidence we have right now is the more ventilation, the better. One question I often get is, should you open windows? And the answer to that is, yeah, certainly. It's better than nothing, but I lose any ability to tell you how much ventilation you're going to get. So that's what the picture on this slide shows. This is actually data we took from my house a few years ago. We measured the air exchange rate on a very high frequency for a year in my house. And you can see there's a wide distribution every month. That's very typical. Ventilation, especially in a building like a house, is very variable and does vary over time. But the important thing, and the reason I wanted to show you this picture, is if you look in the summer, kind of May, June, July, and so on, we're most likely to have the windows open during that time, and the air exchange rate is not particularly high during those times. In fact, it's some of the lowest numbers. And that's because opening a window is just a hole. If there's not wind, or in the summer in Toronto, especially the year we did these measurements, there wasn't a very big inside-outside temperature difference. So there's no driving force for air to move through that wall, through that hole of that open window. And so, when you're opening windows, it improves ventilation. How much, I can't tell you. And then also there's a real kind of mixing issue. Very often you can get much better ventilation near the window, but it might have much less of an effect in other places in the room. So open windows, yes, but you might not get everything that you want. Moving on to filtration. What does doing filtration well mean? Well, it means, of course, using a good filter, making sure air goes through it, making sure that filter is installed well so there are no gaps around it, what I call bypass, and making sure you're on top of changing that filter to maintain its performance. So these are data that I showed in the March webinar as well. This is a MERV 14 filter in 20 homes in Toronto. Each symbol is a different home. And this is the real efficiency. So this is a very good filter. And how we would expect it to perform is that black line you can see on the upper right. That's from the standardized test in a lab for this filter. And you can see in some homes it performs relatively close to how we expect. And in other cases, it performs much worse. And so these details of it's insufficient to have a good filter, but you have to install it properly and make sure it's living up to its design intent. I thought I would mention portable filtration as well. And it's the same basic sort of story. You want to use a filter that's producing enough clean air, or what we usually call the clean air delivery rate, or CADR. And you want to make sure you've addressed noise issues. Often air cleaners can be quite loud, and so you have to manage that, which is a lot about managing user expectations. And the story I always tell about this is in my daughter's classroom when they were back in school in the winter. One day she came home, she knew I would be interested. She said, "Oh, we got a HEPA filter in the classroom." I'm like, "Oh, that's fantastic." And I asked her about it 3 or 4 days later, and she was like, "How's the HEPA filter doing?" She's like, "Oh yeah, we turned it off. It was too noisy." And so you have to really manage that issue. You also have to think about placement. So the pictures here are from some simulation and measurement work we did several years ago. This is in a house where we had a particle source, and then we positioned the air cleaner in different spaces in the house. And both a very effective air cleaner with a high CADR and a much less effective one with a low CADR. And you see a real difference in performance for different size particles, depending on placement. And so you really have to think about the placement issue, place it near the source if you know it, or in the center of the room if you don't. And placement can really affect performance. You need to, of course, stay on top of maintenance and changing that filter. And you have to avoid unproven technology. And I'll talk more about unproven technology, but it's things like bipolar ionization, plasma, photocatalytic oxidation, and other such technologies. And I'll talk more about them later on. So given that ventilation and filtration can be effective, what's your goal here? And the goal that most people cite is 6 air change equivalents, or ACH-EQ. From all the measures together. And before I kind of show some calculations, I just want to be very honest that the 6 air change equivalents doesn't have a huge basis in the literature. There is some amount of data from the tuberculosis literature, and there's kind of a more broader argument about at 6 air change equivalents, you're going to turn over the air very rapidly in the air. So any source will not elevate concentrations very much. But it doesn't have, it's not a magic number. And so what I do feel very comfortable saying is that 6 is a lot better than 2. And the difference between 5.5 and 6 in actual risk transmission is kind of unknown. But it's a reasonable target based on the information we have now. And so how you calculate it is you basically take the flow rate, and in some cases the efficiency, and you divide it by the room volume for each of the components you have in the space that address respiratory particles. And that tells you what the total ACH equivalence is. So to make that a little bit more concrete, I want to show a couple of examples. And there's a couple more examples that'll be in the slide deck that's posted for other types of situations. So let's say we have a 1,000 square foot classroom. Sorry, a lot of HVAC work is done in freedom units. And so that's why it's square feet. But anyway, got a 1,000 square foot classroom, 10-foot high ceilings. And let's say we're ventilating quite well. In this case, we've got a ventilation flow rate, a third of which is outdoor air, 2/3 of which is recirculated air. And we have good filters, MERV 13 filters. So if you go through the calculations, you're getting about 2.8 air changes from outdoor ventilation, and predominantly because of the high efficiency of the filters. And by the way, most people use the filter efficiency for 1 to 3 micron particles, which is where we believe a lot of the long range transmission is occurring. And so if you go through that calculation, you're getting closer to 5 from filtration. So you sum those together, you're getting 7.5 air changes equivalent. So this is, I would describe as a very, kind of well ventilated, appropriate space. There's no need here for portable filters. There's some things you should pay attention to. Are you really getting 85% efficiency? Is your flow rate really at the number you set it at? Sometimes there can be controls or other kind of system degradation issues that might make that flow rate smaller. But if this really is what you're getting, this is a reasonable situation. You also have to pay attention to practical things. In this classroom, has someone blocked registers or grills, often because of noise or draft concerns. So you have to pay attention to that. A somewhat messier example is the same size classroom with much less ventilation air and lower efficiency filters. And here you're getting about 1.4 air change equivalents from ventilation, 0.6 air changes per hour from filtration. You sum those together, you've got 2 air change equivalents. And if you're trying to meet that target of 6, you would need to have portable filters with a total CADR of 667 CFM. So that might be 1 very large unit or 2 or 3 smaller units to get that total. And, again, things to pay attention to, the mixing in the space, are the filters being maintained? Are people turning off the filters? So those just go through a couple of examples of how people might get to 6 air change equivalents. And as I said, there's a couple more examples. Some other strategies you should think about is certainly after occupancy room flushouts. The recommendation for ASHRAE, and this will reduce the respiratory particle concentration to 5% of what it was to do 3 volumes of air flush out of the space. And if you don't know the air exchange rate, you can do 2 hours, which is probably an overestimate, but there it is. If you know you have 6 air changes equivalents, you can do it in 30 minutes. But with any flush out, you got to be careful that you're actually getting it to the outside or removing it from the air, not just spreading it to other parts of the building. And you can do it with windows. Again, the same hesitations for windows that I mentioned previously. There are some more advanced strategies that might not be available, but they might be depending on your resource situation. You can use either induct or upper room UV systems. You have to pay attention to sizing, maintenance, environmental control, especially RH, because high RH can diminish the effectiveness of UV, as well as in some UV systems, there might be an ozone emission problem you have to address or hopefully avoid systems like that. So, you do have some other things you can do besides straight ventilation and filtration. There's also some things that you should avoid. And number 1 on this list are unproven air cleaning technologies. And often, if you're looking at different air cleaning technologies, you'll get a lot of marketing claims as well as a lot of test reports from the manufacturer, and things look very good. And there's a long list of things on this slide that kind of go to, even if it looks good in test reports, why that might not translate to real life. And just to hit a couple of these, the top one on the list, high efficiency. So you can have very high efficiency, but very low flow, and that will mean low performance. So you could, for example, take this to its logical extreme. You could have a perfectly efficient air cleaner that has no airflow going through it, and it won't make any difference at all in the space. And so flow matters, and that's why manufacturers it's often easier to get to high efficiency and not pay attention to flow. And then there's a lot of other things. Another example is the blast bullet point here. In some of these devices, there can be a lot of sample variation. So the device that the manufacturer used for their tests might be different from the device that they're selling or that you might install in your building. So there's a lot of reasons to be cautious here, and I would suggest avoiding these technologies. Another approach that I think you should not implement is the idea of plexiglass barriers. There is, first of all, they're not that effective because airflows just move around them and carry some of the respiratory droplets with them. But there's actually some evidence, and this paper is one example of them, where you can effectively trap potentially infected air inside of a space, a contained space or a partially contained space with a plexiglass barrier and actually enhance transmission. So better to use technologies that have proven track records. So I want to specifically address some of the questions that came up from the last webinar. The first one is, should you monitor CO2? And I have two answers to this question. The most common answer is no. If you're either maintenance or resource constrained or both, if you don't have the bandwidth in terms of personnel to actually work with those sensors and have a good action plan on what to do based on what the sensor is telling you, you're much better off putting your resources into filtration and ventilation. However, if you've already done everything you can with filtration and ventilation and you have that resources and that bandwidth, then absolutely it can be a nice tool to have in your arsenal. If you do it, make sure you know your sensor well. There's a lot of issues with thresholding, backgrounding, how they deal with drift, because most CO2 sensors drift over time, how they interact with humidity. So really know your sensor well so you know what an elevated reading means. They're most appropriate as a relative measure, not an absolute measure. If you have a space that's usually at 700 ppm of carbon dioxide and suddenly one day it's at 1400 ppm, that's an indication that something has changed, and you should probably understand what that something is and address it. If you're willing to put in the time to do some data analysis, you can directly measure things like the ventilation, air changes, the fraction of outdoor air that you're getting. You can pair it with a low-cost particle sensor and get an estimate of air change equivalence. And a very valuable thing you can do is evaluate your measures. What happens when you open the windows? Does it change it? What happens when you increase the ventilation? Does it change it? And so you can use them to give you information about things that you might do in the space, as well as they have some value if you can tell people how to interpret them. And you do have to spend some effort here. You don't want people to think that a slightly elevated CO2 concentration is a problem, because it isn't necessarily a problem. So you have to teach people what it means and this kind of idea of it as a relative measure. So if you're going to use them, commit to them and use them well. Another question that I get a fair amount is, in the past, people have bought these air cleaners that, have unproven technologies. What should you do? The first thing I would say you should do is you should probably consider disabling it. Some of these devices can cause harms in the form of byproducts. So this is one article from the literature that showed a bipolar ionization device. The figure on the left shows the particle concentrations with the ionizer on versus off. And you can see that it's a very small difference, not statistically significant in any case. And then you can also see in the picture on the right that there can be a production of some byproducts. Whether there's enough of those byproducts to cause concern, and whether even some of those byproducts are a concern at all is another question altogether. But the fact is there is some chemistry going on with some of these devices. So I would suggest disabling them. And if you have this problem that you've procured one or procured many of them and people are asking questions about why they're being disabled, I think you just have to, kind of explain the rationale. And if you're a decision maker and someone is coming to you and saying, hey, look, I think we should disable these things, understand that people did not have the same information available to them when they did the procurement as I think we do now. Another question is, I talked some about high-risk spaces and being protective in high-risk spaces, so I better define them. Fundamentally, a high-risk space is one that hits, two of the three main trigger factors: poorly ventilated spaces where people spend a lot of time in them, and spaces that are crowded. If you have any two of those, or even any one of those, you should think about that as a high-risk space. There's some other factors on this slide too, based on where the space is and who's in it. Is there more likely to be COVID positive individuals? Is it a cafeteria or a lunchroom where people aren't wearing masks? Is it an environment where there's vocalization and people are producing more respiratory droplets? Are there environmental conditions, either cold or very dry or very humid, where there's likely to be more transmission? And there's a lot of examples of these in the literature that are listed here. And so if you have a high-risk space, you have to address it, and you have to do measures more than you would in a lower risk space. So another way of saying that is target your risk to your measures. And then, I've talked a lot about good indoor air quality. How do you know when you have it? It's a very good question, but unfortunately, there's no really great answer to this. My suggestion is you define it operationally with an assessment. Do it with, have you identified sources and controlled for the emission from those sources? Have you assessed and made sure you have good ventilation in the spaces in your building? And where possible, have you supplemented with either portable or central filtration? So that to me is the best. If you've gone through that process, that is most likely going to lead to high IAQ. People like to measure things, and I'm actually, it's very hard to measure well because there are so many things in indoor air that might be an issue. So if you're going to monitor, an important thing to monitor for is PM 2.5, and the official recommendations are it should be as low as possible. If you really need a number, I'll tell you below 4 micrograms per meter cubed, but I don't believe as low as possible is the right answer there. Carbon dioxide, a lot of issues, as I talked about with carbon dioxide, but kind of keep it below 800 ppm. A lot of people like to measure total volatile organic compounds. There's not a connection there to indoor air quality, unfortunately, so I can't give you a range there. Formaldehyde, you should probably keep it low, certainly below, about 10 or 15 ppb or so. If you had to give me a number, I'd say keep it below 8. But formaldehyde is not necessarily easy to measure, is certainly not in a continuous manner, especially at the low concentrations that we'd like to keep it at. So, I suggest the operational definition rather than the monitoring definition for indoor air quality. So as I get towards the end here, I wanted to talk about just some parting comments, some things we should think about. So let's say I'm entirely wrong that filtration and ventilation do anything for COVID-19. I would point out that the worst case scenario that we have is that we only end up improving indoor air quality. So the picture on the left here is from a review about schools. And it shows that when we improve ventilation rate in schools, we see improvement in cognitive function, we see improvement in standardized test scores, and we see reduced absenteeism. So that's an example of an environment where good indoor air quality is important to the function of the environment. Another example is the figure on the right. This looks at the benefit to cost ratio in different types of buildings for different levels of filters. And there's 4 studies represented here. Each use different methodologies, and each were in different places in the world. And that's why you see a range here. But the important thing here is all of these studies found a benefit to cost ratio improvement kind of in the range of about 10 to 100, meaning that for every dollar you spend on filtration, you get a return of $10 to $100. And so that's a big part of the reason why filters are worth investing in. I would encourage you to really draw the big picture on economics here. by the way, most of that benefit is avoided healthcare costs. A second comment here is because we've systematically not paid a lot of attention to HVAC systems, we have some opportunities. Number one is we typically operate HVAC systems for things like comfort and energy. And, we could easily also optimize for indoor air quality. It might take some compromises, it might take a different kind of viewpoint on systems, but that should at least be part of the discussion now. I think one of the biggest opportunities we've missed in this pandemic is we haven't done research that has, or outbreak investigation, that has captured the role of building factors. So we can't say a lot epidemiologically about things like filters and ventilation because we haven't collected the data. And going forward, I think we should do a lot better at that. Also, we need a formal evidence basis, much stronger than we have now for ventilation and filtration. And what we've really kind of defaulted to is saying, well, we don't have evidence of benefit, so we can't recommend these things. And I'm going to say that, first of all, the absence of the evidence is not evidence of anything other than the absence of evidence, but also that we really need to collect this evidence. We really need to know whether filters and ventilation work. And then the last comment I'll make is that there's also a challenge here. We've kind of systematically underinvested in HVAC systems, and that's led to the void being filled by, in some cases, manufacturers of air cleaning products in particular, who are taking advantage of that vacuum. And a last important, but I'll do it rapidly, parting comment is that we know that poor indoor air quality disproportionately impacts some parts of the population. We know housing quality is an important factor in some health disparities. And so I believe that addressing indoor air quality, it's not everything, but it should certainly be part of the national conversation. And I think we can use COVID-19 and the engagement we see with COVID-19 as a catalyst for this engagement. And we're not unique in the world that we haven't invested in indoor air. And I think Canada could really take ownership and have leadership on this issue. So to summarize here, certainly filtration and ventilation have a role in protecting us. They're not magic. There's no silver bullets here. They have to be done well. And, the suggested approach is hopefully more like common sense at this point. Certainly all the primary measures like masks, vaccination, everything else first. Maybe let's include fixing the really deficient, poorly ventilated buildings in that, and then increase ventilation and filtration from there. Especially address those high-risk spaces and appropriately value the benefits of indoor air. And I'll wrap up there and be glad to take questions.
Thank you so much, Jeff. You've left plenty of time for questions, and just want to thank you again for making, I think, what has been a complicated and I think very consternating topic for many in the audience into what is if not simple, at least something that we can all individually and as institutions take some positive steps on. And I really like and appreciate that you have ended the presentation with the opportunities that we have to move forward on not just ventilation and filtration, but indoor air quality as an overarching objective. That we have some important opportunities to try and harness through the pandemic. So thank you so much for that and for the practical examples you gave. I will now turn it over for the Q&A part of the session. Please continue to enter your questions into the Q&A pod if you haven't already had an opportunity to do so. There's already some that have popped up. And I just want to reiterate that Jeff's first presentation back from March is available through the PHO events website. And this session is also being recorded and will be available for viewing later on as well. So, so please do share with your colleagues, and you know, if you wish, come back and hear it again. So Jeff, just turning over to the Q&A pod, there's several that's coming up. One is a comment that for inhalable particulates, ISO 7708 clearly defines a size range of inhalable particulates, which notes that inhalable particulate matter is typically less than 100 microns. Any follow-up on that?
Yes, so there's an excellent article that talks about where the 5-micron distinction came from, and it's almost certainly came from a mistake, and the real number should be more like 100 microns. The comment I would make about inhalability is that's absolutely right, but it's very complicated because different sized particles end up in different places in our respiratory system, and different sized particles are more or less likely to contain infectious disease. And so it's not kind of a one-to-one thing, but absolutely, I think we should be worrying about much larger particles than 5 microns in a community setting.
And I would think they're dynamic in terms of size as well as they move through the environment.
Oh, absolutely. So especially if we're talking about respiratory droplets, there's an equilibration between the water in the droplet and the relative humidity in the air. And again, so droplets shrink in dry conditions. That's very well known. There's excellent research on that. But it's complicated because you can think about a droplet like a salt water particle. And so as water evaporates, the salt concentration goes up, and that can be adverse to infectivity for some infectious diseases. So again, I know I say it's complicated a lot, but it is definitely an issue. But there's definitely a lot of dynamics here. And I think that maybe, if I can be optimistic, one thing that's come out of the pandemic is that, you know, we really have to do a better job of kind of, there's the public health, there's the medical side, there's the aerosol science, and there's the building science side, and all have relevant comments on the problem.
And we need to document that more, which I think you know was part of your parting comments. In concert and not just separately, just I think is excellent. Another couple of questions that's you know referring, I think, to your the 6 ACH equivalent goal or target, but I'm going to combine that with another one that came through. So there's a question: so would 5 ACH be acceptable and 4 not? And do you need to consider the number of people in the room when you perform those calculations?
Great questions. So first of all, you know, it's a continuum, right? So I'm always going to like a higher number than a lower number. But, you know, if you can get to 5 and getting to 6 would cause a whole bunch of other issues, you know, comfort issues, maybe cost issues you don't have or something. I think people can weight those themselves. And so, you know, there is no safe number. Even, you know, in an operating room, you might see, depending on the operating room, a number like 15 or 20. And obviously that's much safer. But also the risk is much higher because of some of the things that go on in the space. And so, you know, you kind of have to see it as a goal, not as an absolute, I guess is the thing I would say. Do you consider the number of people in the space? That's a really good question. So I guess I would answer that this way. Certainly the number of the people in the space influence how much ventilation air you need in the space, because one of the primary functions of ventilation is to get rid of the pollutants that we produce, called bioeffluents. And so, you know, that should influence your ventilation rate. Should it influence your ACH equivalents? I would say it this way. An environment that's crowded certainly has a higher risk. And so I would certainly address that risk. Whether that risk can be addressed appropriately with ventilation, though, is a really good question, because when you have a lot of people close together, you're going to see a lot more kind of close contact, which ventilation has a very weak effect on, if an effect at all, in some environments. And so I would say you've certainly got a risk to manage, and it might not be a risk managed best with ventilation. You might want to look at something like an upper room UV system or something like that in a crowded environment. So that was kind of a non-answer, but kind of an answer to it.
So helpful, and I think it's how are we addressing COVID, which I think is on many people's minds, versus how are we addressing indoor air quality, which, as you've demonstrated, is a very important and neglected area aspect of environmental health. Just a clarification is being requested on plexiglass. So are you meaning that plexiglass barriers are not recommended in all settings?
That is correct. The comment I would make about plexiglass barriers is they do serve some role in terms of enforcing physical distancing, right? So I have seen some use of plexiglass barriers where maybe they were put there to stop transmission, which they're maybe not doing a very good job of, but they certainly help keep people apart in some cases. And so just be really sure, if you're using a plexiglass barrier to stop, long range airborne transmission, no, that's not going to work. If you're using it to enforce people standing in line at certain places or protecting, retail staff by keeping people away from them, I see a lot of benefit there.
Okay. There's also a request for you to, if you could briefly summarize the evidence from tuberculosis that suggests 6-ACH is good ventilation.
Yeah, so there's a series of papers that I might not be capturing all of them, that start in about the 1980s and go through the 1990s, that do a bunch of series of tests with, in some cases with tuberculosis patients, but in most cases with a surrogate aerosol, and look at what level of reduction you get by different measures. And the 6-ACH number is reflected in some healthcare standards. And so that's the best I've been able to trace the number to. But I fully admit we're taking it a little out of context, and I'm mostly using it because a lot of other people are using it.
Okay. Thank you. A series of questions related to dental environments. So a lot of information required when it comes to dental offices where aerosols and droplets are created, and the discussion about follow times that may be necessary could potentially be true in the acute healthcare settings as well. Do you have any recommendations for these scenarios?
Okay, so I did a lot of work with dentists early on in the pandemic, over a year ago. And the comment I would make is, dentistry is regulated by a dental regulator. So what I think is obviously less important than what regulatory guidelines you're trying to meet. I will say that I think the risk in dental offices is overstated. First of all, a lot of the things that we think of as aerosol generating procedures are not actually aerosol generating procedures. And second of all, the risk can be managed in the same way we manage the risk in other environments, obviously through PPE for the staff, through ventilation and filtration, and through paying attention to things like maybe open operatories, for example, are not such a great idea unless you're really managing the ventilation and the airflows. And so we have a bunch of strategies, and I think that many dentists are doing it very, very safely. I have not heard of transmission events associated with dentist's office. Not to say that there aren't, I just haven't heard of any. And so I think it's a very manageable risk. And I think that the very long fallow times, at least we saw early in the pandemic, were not at all consistent with the evidence.
Okay, thanks so much. There's a question that about, that's very topical right now with the very warm weather. Many settings in the community do not have central air conditioning. There are ventilation, filtration considerations. Well, are there ventilation filtration considerations when thinking about using portable AC units? And I know that this applies to many institutional settings as well, such as long-term care homes. Any advice for those settings?
Yeah, so look, we had a climate crisis a long time ago. We have a climate crisis now. We're seeing just how devastating extreme heat events can be in Canada and in other places in the world. And, this has been a fact of our recent history. So I think, air conditioning is enormously important, kind of portable or window unit air conditioning, is needed, and we have to manage the heat risk. I would make two specific comments. One is most of those units are very airflow limited, so you can't have good filtration. So you just have to do the filtration or the ventilation separate from that. And you might have to, ventilation comes with a huge humidity penalty in particular in some climates. So you might have to manage that, for example, by having supplementary dehumidification or doing some amount of energy exchange to not add a bunch of really humid air to the space. But the other comment I would make is that a strategy that has been used very effectively for extreme heat events is to have, centralized cooling spaces. So it can be a real problem to cool a whole apartment building, especially an older building that doesn't have central air conditioning. But we could make a space, some common area that is got cooling there, and that's been done very successfully in a lot of buildings, and just make sure that the people are getting into that space as needed. And the follow-on to that is, why not make this a respiratory disease safe space too? Make sure there's excellent filtration and ventilation in that space, and then it becomes a safe space, not just from the heat event, but from respiratory disease as well.
Some excellent advice. Thank you. There's also a comment on kind of the bigger or request for comment on some of the bigger picture issues you mentioned. So what would be the best way to unify and improve municipal, provincial, or national standards and policies when it comes to building indoor air quality?
Yeah, I mean, this is one of my favorite questions, and I have a lot to say about it, but to say it very briefly, the fundamental problem with indoor air is that it is political suicide for a politician to take it on. If they tell people that their homes are not sanctuaries, they will not get reelected. And so I think that we can't use a model that we use for outdoor air, for drinking water, or for other environmental hazards. We have to take a different approach. Part one of that approach is, I think we need government ownership of this problem. And I can imagine an agency who's charged with two things. One, regulating the indoor air products and strategies that are in the market, but more importantly, providing information to consumers. And I think if we saw that, and countries that do some flavor of that definitely see a much better indoor air because people have information and resources available to them. I really think, getting to one of the comments I made, I really think we have an enormous opportunity here as a society to not just think about, kind of indoor air for the wealthy, but to think about indoor air for the people where it will have the most benefit, which are very often racialized or other marginalized populations. And so let's target those resources. Indoor air is certainly not the only thing, and probably isn't even the most important thing. For example, housing availability is probably in many situations more important than housing quality. But that doesn't mean that we should kind of forget about housing quality and that we shouldn't address it. And so, I think we have a real opportunity for change here. And I think we have to think about alternative models. I think the regulatory model is probably not going to work. But I think we have other models. We have, information-based models. We have different ways of looking at the motivation around things like cognitive function and decision-making, that we can make a very clear economic case for improving indoor air quality. And I guess that we should be doing that in a much more systematic manner.
Thank you. You mentioned the gap, or at least providing information to consumers, and I am aware that that there is some information available through Health Canada, for instance, or other other agencies that that have that mandate. Are there particular gaps that you see in the information itself, or is it more the approach that you see that needs, could is there an opportunity in terms of the approach?
Well, two parts of the answer to that question. The first part, and this is obviously self-serving, there are definitely gaps that we need research on, as someone who does indoor air research. But if you look at expenditures on indoor air research, they're a tiny fraction of what we spend on outdoor air research or drinking water research or anything else. And so I guess let's just bring the research expenditures and the expertise in line with where the risk occurs. And then the second comment I would make is I absolutely think there are approach opportunities. And in particular, there is, like, I can tell someone what to do to make the indoor air better in their home, let's say. But people actually doing it is something else. And so I think we need people not like me, people who are experts in communication and in risk communication particularly, to look at what are the effective ways of messaging some of this stuff. So it's easy to tell people to use a range hood fan, but what happens if the range hood fan doesn't work or doesn't exist at all, or it's really loud, or any number of other things. So we have to kind of think about what actually works. And I'm going to predict that there are opportunities to make things that actually work that aren't even on the table right now and should be.
Thank you. Can you, another question, can you elaborate on why high efficiency for very small particles is not a good thing? Aren't viral loads in particles such as COVID-19 at 1.2 microns, which is a very small particle?
Yeah, okay, so there's a few parts to the answer. The first part is the actual virus itself is a number like 100 nanometers or 0.1 microns or so. But the virus doesn't exist by itself. It exists even as a singlet is very rare, but it exists in a droplet, often with multiple viral particles in it. So it's much larger than that. The reason though why manufacturers like to tell you their efficiency for very small particles is efficiency is often U-shaped for filters, meaning it's easy to remove very small particles and it's easy to remove relatively large particles. And it's the particles in between, which are about 0.1 to 0.3 microns, which are the hardest to be removed. And I know that sounds counterintuitive, but it comes from the fact that very small particles are removed by something called Brownian diffusion. And so what a lot of manufacturers do is their efficiency doesn't look that good at, let's say, 0.3 microns. So instead they'll go to a much smaller size and kind of prey on the fact that most people think it's harder to filter very small particles than those still small but larger particles.
Thanks, Jeff. Recently, CBC had an investigative report about a makeshift air filter, and I actually have a feeling that you might have been the expert that they interviewed.
Yep.
Yeah, being equally effective or better than some actual marketed air filters. Could you provide a comment on this?
Yeah, sure. So the basic idea here is you use a box fan and you attach a filter to it, an ordinary furnace filter, hopefully one of relatively high efficiency. And the box fan moves a lot of air and the filter is a good filter. So you essentially you've made yourself a homemade portable air cleaner. And there's lots of improvements you can make on this. You can make a box out of filters so you get even more airflow. You can, I saw recently a presentation where someone had added a heat exchanger so they could also bring in some outdoor air and without quite the same penalty. So they were getting both filtration and ventilation. So there's all these cool things you can do. And it's very simple and, it's a cheap way. I feel a little bit about it like, I'm glad it's there, but I feel a little bit about it like I do about open windows. Obviously a product like that is not going to be as robust, and not everyone has the time and the skills to source the materials and actually make it. And so I hope that we're doing that as a stopgap measure. Maybe there's procurement issues or other things, and we're not using that as a permanent solution. But just like with open windows, I'd much rather someone use a solution like that than nothing, because it's a lot better and it's actually surprisingly good. But I hope that we don't stop there and we keep going.
Okay, hoping to squeeze in one more. We are at time, so I think this might have to be the last question, but referring back to your presentation and some of your comments just now, for overall indoor air quality improvement, then do the aspects that you summarize in terms of the strategies have to be monitored or measured seasonally or on some kind of an schedule to confirm that these measures are working?
Yeah, so indoor air is very dynamic. If you look at almost any pollutant, you're going to see a low baseline and periodic high excursions when a source is active. And so you can't measure for short times and learn things. So I'm a big fan of, if you're going to do it, do some sort of continuous or at least relatively frequent monitoring. And the goal is to capture that variation, right? So if you measure only on weekends in an office building, you're going to see something very different and maybe not that relevant. So you have to kind of think about what you're measuring, what's going on in the building. And if you are doing episodic measurements, make sure you're capturing the variation.
Great. Jeff, I really wish we could get to more of these questions, but we are at 1:01 now, and our time is up. And I'm sure yourself, and and the participants of this webinar have to run to other commitments. So I really want to thank you again for making this topic sort of accessible for such a broad audience. We hope that it has been useful for members of our audience, and perhaps we might even have you back at a future session. But I want to extend my thanks again for your part 2 on indoor air quality in the time of COVID.
Yeah, thanks very much for the invitation, and thanks everyone for your participation.